Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by EUROTIMES. We're here at the 32nd Congress of the ESCRS in London. What is the best approach to dealing with astigmatism during and after cataract and refractive surgery? We're here with Dr. Noel Alpins of Melbourne, Australia to discuss that question. Welcome, Noel. Thanks so much for coming.
Sean, thank you for the invitation.
First, if you could give us some context, what is the issue or problem with current formula now in use?
Well, when the formulae for calculating implants, toric implants for cataract surgery, for example, the most frustrating thing I think for surgeons is the inability to have a number that represents the corneal astigmatism and the meridian accurately, because there's so many different inputs you have. There's the IOL master, the simulated keratometry or the manual keratometry and other things, and they're often different. So the one number, which is a variable, you're trying to line it up with, particularly with a meridian, can be a conundrum. And so we've developed a new parameter called CORT, which stands for corneal topographic astigmatism, which compared to SIMK, which only uses one ring, this uses 16, 18 or 20 rings from the topographer. And it takes an average. So if there's any amount of irregularity, it gets ironed out by the averaging process. And so you have a very accurate number with more reliability, less variability, and it's actually closest to the manifest refractive cylinder, which is really the gold standard. The second part about it for planning cataract surgery with toric implants is there's so many different calculators on the market, a calculator for every lens. So we developed a calculator that has all the lenses on the one calculator, and it has the three most important components, which is variably missing from some of the others. Axial length, effective lens position, and optimized lens constants. They're the key essentials of accurate biometry, and all those aspects are all on our calculator, which is really a generic calculator that can calculate for any one of the 10 different implants that are available in the world for treating astigmatism with toric implants.
Is this all part of the ASSORT program?
It's a free application. The answer is yes, it's part of the ASSORT program, and it's also part of some free applications we have on the web. So you can go to the assort.com, that's ASSORT.com on the World Wide Web, and we have 4 free calculators there, one of which is the toric calculator. So it's free to use, it's accurate, and it's handy. And so that's part of the ASSORT surgical management systems, of which there's 4 parts. That's the free web-based calculator part of it, which can be seen on our website.
Now, how did you develop this? Did you come about this just from out of virtue of necessity and your own experience? Did you decide you didn't like what you were getting and needed to improve it?
In general, the answer is yes. I think astigmatism hasn't been a well-understood subject over the years, and we've tried to improve that by developing new formulas, just developing the method of outcome analysis, which has enabled us to develop new techniques for actually planning the surgery, using vector planning. So just in brief, using vector planning, we actually, rather than treating just by refractive parameters alone, we're going to bring the corneal topography into the treatment plan. And that's why it was so important to develop a better corneal parameter, which CORT is.
Now, I understand you've recently developed a new formula involving corneal coupling. What is corneal coupling, and how is that going to improve our results?
Well, corneal coupling is a phenomenon of the astigmatism treatment. And it's actually a complicated subject which we published, is going to become published in November, December in the Journal of Cataract and Refractive Surgery this year. To try and simplify a complicated subject, we've actually put together an application on the web to make it easier for doctors to work it out. So the thing about coupling is that when you do an astigmatic treatment, it's going to affect the sphere. And to try and make this as simple as possible, I've tried to use the analogy of a tennis ball that's been cut in half. So in a spherical eye, obviously the tennis ball is round, but when it becomes astigmatic, the steep meridian is here and the flat meridian is there. So if you do an incision to sphericize the cornea, you're going to make an incision there, like a limbo relaxed incision there, and right there. And so when you sphericize the cornea, it goes spherical. So instead of being, for example, 46 and 42 as the corneal keratometries, it's going to become 44 and 44, which means you have 100% coupling. You've got no change in the sphere. But if you start off with 46 and 42 and you sphericize the cornea with laser surgery, it has 0% coupling because it now becomes 42 and 42. So you're transferring some of that astigmatic treatment into a spherical change. And so the best way that I like to try and explain that is really the circumference has changed and you have a smaller circumference, which means you've changed the spherical equivalent. So what we've done with the coupling calculations, we've now developed the coupling constant, the coupling ratio, and a new parameter called coupling adjustment. So that if you're not getting a spherical result, how much of that astigmatism treatment do you need to transfer onto the sphere to make sure you're maintaining a planar result and not creating myopia or hyperopia?
Now, how will that formula interface with current platforms?
At the moment, think of it this way. In the past, we've had regression formulae like the SRK, SRK2, SRKT for implants, which have now blended into the more theoretical formulae of Hoffer, Holliday and Haggis, which are more accurate. So think of it now, the laser companies have been using regression formulae to try and maintain the sphericity of the cornea to be planar. But as the treatment for astigmatism gets higher, 2, 3, 4 or 5 diopters, it's harder to maintain. And so if it isn't being maintained, how are you going to adjust for it? So it is being done now quite well, but having now like a theoretical formula is going to make it better.
Very good. Thank you so much for joining us.
Well, thank you for your questions and the invitation.
Thank you for joining us. For more information on this and related subjects, please visit us at eurotimes.org.